Well, welcome everybody. We're going to do the Lever chapter on metabolic disorders, which is an interesting chapter. It kind of has all these unique conditions that have systemic involvement and secondary cutaneous involvement. That's kind of the binding theme with this. So without further ado, we'll start off with a little PowerPoint presentation, and then I'll go into some slides at the end of the talk. So the first condition is amyloid. We've all heard of this. We all love the amyloid protein, which consists of extracellular proteinaceous deposits of this amorphous eosinophilic and hyaline material. Very characteristic look, although it can be presented or deposited to different degrees depending on what kind of disorder, in particular whether it's localized or systemic, and we'll get into that in a little bit. Congo red with apple green birefringes, that's kind of its claim to fame. I'll show some images of that in a little bit. But we also have a good staining. I've had some good luck with crystal violet stain, methyl violet. By EM, which we don't do too often now, you do see this cross beta pleated sheet, which is kind of a good board's fodder material, though, to be honest, it's like I said, it's not a very commonly done test nowadays. So systemically, we have two types. We have the AL and the AA amyloid, and clinically, we all know that this can present with petechia, purpura, ecchymosis, and this all comes from involvement of blood vessels. Amyloid preferentially involves blood vessel walls, and it can cause weakening and eventual hemorrhage, and that's where you get the pinch purpura. If in doubt, you can do fine needle aspirates of fatty tissue, which has actually a very high sensitivity and specificity. So systemic amyloid, the first type I mentioned is AA, and this is the kind that you see resulting from chronic inflammatory disease. Back in the day when tuberculosis was a lot more common, we would see that secondary systemic amyloid from that condition, but others as well. Usually you don't get skin disease in this type, so we're not going to go too much into this one. But the protein is the serum amyloid A protein produced by the liver. And this is in contrast to AL type amyloid, which results from a plasma cell dyscrasia. So patients need to be worked up for that. The protein in question here is this monoclonal kappa or lambda protein, and you can involve multiple organs. So here's kind of a classic pinch purpura. This is from the Lever textbook right here, good distribution location, and the macroglossia from involvement of the tongue. And this is what I was referring to earlier, where you can get this preferential involvement of blood vessels, which is what we have right here. These are markedly thickened blood vessel walls, and they have this real eosinophilic hyaline material that's abnormally distending the wall and weakening it in effect. So that's amyloid involvement of vessels. And here's another photo from Whedon's skin pathology showing this kind of classic amorphous eosinophilic nodular deposit of amyloid. And this patient probably had systemic amyloid. So this is different from primary localized cutaneous amyloid, which looks very different histopathologically as well as clinically. Two types are lichen and macular amyloid, basically different manifestations of the same disease. I'll get a little bit into that. And the derivation of the protein is very different. These are from keratinocytic proteins, keratin filaments actually, and they say you can stain positively for cytokeratin by immunohistochemistry. It's a little tricky. Tried it a few times with limited success, but in any case, the material is derived from keratinocyte proteins. And very commonly, actually, we see secondary amyloid in things like basal cell carcinomas, tumors, or anything that have been around for a while. It's actually probably the one scenario where in daily derm path practice, you see amyloid most commonly. So lichen amyloid, as I said, is related to macular amyloid. Only difference really being is that you have superimposed lichen simplex chronicus on the epidermis. So it's probably produced by scratching. It makes sense that it's on the legs, an accessible area for scratching. And then this is kind of that classic rippled pattern for primary cutaneous amyloid. And here's an example from Whedon where we get this hyperkeratosis, probably again, like from lichen simplex chronicus-like changes and deposits of this amorphous material, just very limited amounts. It's actually can be very tricky to see. I'd file it under this sort of invisible dermatoses or dermatosis that's hard to see. if you're doing like your daily sign out. But this is a good example of like an amyloid. And if you want to do your stains, you can to highlight it. You often have these necrotic keratinocytes, which is what we're seeing right here, which makes sense because if this is something that's derived from the cytokeratin proteins, then it makes sense that you have a few apoptotic ones. Again, you can do your Congo red or crystal violet. And here is actually an example of the crystal violet. Very nice stain. This is from Whedon's pathology. Nice violet appearance to it. And this example of primary cutaneous amyloid. So there's one particular variant that's kind of interesting, this nodular localized cutaneous amyloid, which if you showed a biopsy of this, it'd be very difficult for me to tell the difference between that and other systemic types of amyloid. And it's in contrast to primary cutaneous, which the ones I just showed you, which as you saw are much more limited in extent. So these are similar to AL, but no systemic disease, as the name implies, localized cutaneous. You can get one or several nodules on the leg or face, and this is probably derived locally from plasma cells, some of which can be clonal. So it's almost like a limited form of AL type amyloid. Histologic appearance is similar to systemic AL, and like I said, you can have that lymphoplasmacytic infiltrate. So we're going to change gears, talk a little bit about colloid milium and nodular colloid degeneration. Not going to go too much into all the types, but just to let you know, I listed the types here in case you're interested, and as well as their derivation, the juvenile form. Colloid is probably epidermal in origin, and others it's dermal. Congo red staining not always the most reliable, so it may help you if you have under the microscope this difficulty distinguishing this from amyloid, because amyloid should stain nicely. And you have different ultrastructural qualities. So despite the clinical or the histopathologic appearance, pretty similar to amyloid, it's actually different qualities. Here's a nice clinical photo from liver. So you can see here, I'm showing this image from liver as well, the deposits are very similar. You have this clefting, very similar to amyloid. You have this clefting, you have this amorphous eosinophilic material. I would approach this thinking that the first thing that would come to mind is that this would be amyloid. So you'd really need a lot of CPC to tell the difference. Lipoid proteinosis, this is a mouthful. I'll try saying hyalinosis cutis et MUCOSAE or URBACH-WIETHE disease. I'll mention it really briefly again, but I'm mentioning here, the point I'm trying to make is that these are all kind of amyloid mimics, but this condition in particular, autosomal recessive, you get this papular nodular lesions of the face, beaded nodules of the eyelids, involvement of the elbow, hands, knees, the tongue, and the frenulum and vocal cords, giving these patients often have hoarseness, so that's a good thing to know for diagnosis. These patients can have pitted pock-like scars, neuropsychiatric symptoms. And then what interests us here in, as far as derm path is you have this extensive cutaneous deposits of amorphous eosinophilic material, which surrounds capillaries and sweat coils. It can be PAS positive, Alcian blue and oil red O, and Sudan black. Actually never seen a case, but except for in conferences and things like that. But again, I kind of file it under things that have a similar appearance under the microscope to amyloid. CPC will again be very helpful in distinguishing all these conditions. For board's fodder, they like to talk about this extracellular matrix protein 1, which is has mutated in this condition. And here we see again involvement. This is a picture from Whedon, and again you have this amorphic eosinophilic material. It'd be very difficult for me to tell this from the other deposition processes we were just talking about, including amyloid. Okay, so we're going to shift gears a little bit and talk about porphyria. Whole bunch of types of porphyria. We're not going to go into all of them. I just mentioned a couple of highlights of 2 of them, but there's 8 types, and of course abnormalities in porphyrin metabolism. So I wanted to talk about erythropoietic protoporphyria. This condition you probably will see. I've seen 1 or 2 cases of it. These patients have pruritic and burning erythema, superficial scarring, thickening of skin or vesicle formation, often starting at a young age. As far as diagnostic purposes, you have this red fluorescing erythrocytes. Protoporphyrin is not found in the urine, and the mutation is in ferrochelatase. So here's an example, and again, similar to the other ones, the amyloid that we were just talking about, other deposition disorders, lots of eosinophilic material. So very difficult to tell the difference from some of the other conditions that have deposition. So for PCT is the big one. That's the one that's you will definitely come into or encounter in your practice. We certainly do. You have the three types, the three forms: the sporadic, which is the most common, familial, and the hepatoerythropoietic. The big thing is the uroporphyrinogen decarboxylase, which is the enzyme that's involved in this condition. And often I think of this as kind of being a two-hit type of thing. So you get the genetic problem, and then you get something else that gives you damage to the liver. For example, in patients who abuse ethanol, and that's what causes kind of puts it over the edge. You get blisters from sun exposure. You get minor trauma. Often, as would make sense, sun-exposed areas, dorsum of the hands and face, scarring, milia, and hypertrichosis. So what do we see? We see homogeneous pale eosinophilic deposits in the vicinity of blood vessels. Seems to be a common theme that we're seeing here. A lot of blood vessels tend to be involved in these conditions. And this is in the papillary dermis. And of course, you'll get the classic subepidermal cell pore blister, which I'll show you examples of. This is a PAS positive material. And as I showed you, this example of erythropoietic protoporphyria can have much more extensive deposition compared to PCT. Okay, I just mentioned the subepidermal blisters. You can get festooning of the papillary dermis. Again, I'll show examples of this. This is from results from rigid papillary dermis. That's where you get that. And the famous caterpillar bodies, which I'll show you. Here's a clinical image from liver. Okay, so here we see, this is from Ryan Hick on Twitter, a very nice example of a caterpillar body. Here we have a subepidermal blister. And this, if you wanted to stain, would be positive for PAS, but no need here because we got such a nice example overall. And here's another image from Wheaton showing this kind of same sort of thing, this festooning right here. This is from rigid papillary structures, and that's why you get the, in addition to the subepi blister, you get this pushing up of these papillary structures into the blister. And this is another example of the same thing. Basically, these papillary structures, the papillary dermis becomes rigid, and that's why you have this festooning effect. And if you want to, you can do a PAS stain, which nicely highlights this thickened material, PAS positive material around the blood vessels. It can be helpful in diagnosis. So the pathogenesis, this is basement membrane material. So you get multiplication of the basal lamina. That's what's going on right here, actually. Stains for anti-type 4 collagen. If you wanted to do those, you can. PAS, we find, works. It's much cheaper. It's easy to do. And the DIF shows some deposition around vessels and at the DEJ. It's of immunoglobulin. This is just probably trapped immunoglobulin. This is not an immunobolus process, but it's important to be aware to not overcall an immunobolus thing. So I'll mention PCT really quickly because often we'll see this being on the differential diagnosis, and histopathologically, it's really identical to PCT. Porphyria, cutaneous, tarda, and PCT will show near identical causes or presentation histologically. So don't ask us to tell the difference because under the microscope, we can't tell the difference. It's going to be, again, a CPC. These are patients with chronic renal failure. Maybe they've taken some of the drugs that can incite this condition. But the big thing is these patients have normal porphyrin levels, and so that's helpful distinguishing features. But again, histology is identical to PCT. Okay, so we'll switch now to calcinosis cutis. Very common to see calcium deposits in the skin, but you have all these types here which I've listed: metastatic, dystrophic, idiopathic subepidermal calcified nodules. So I'll mention these a little bit. So metastatic calcification, as the name implies, is really a systemic condition. So these are patients often that are very sick. They may have hypercalcemia, they may have hyperphosphatemia, and in general you have the involvement of the media of the arteries, visceral organs, and subcutaneous tissues. That's why you get these palpable hard nodules. And these are a few of these types, and I want to really kind of focus on the big one here, calciphylaxis. So this is one that you'll definitely see in practice. We certainly do. and it's important to know this one because of the implications of it. These patients can have quite a high degree of mortality, 60 to 80%. So that's why it's important to be familiar with this condition. Clinically, they can have bulla ulcers, livedo reticularis, like lesions, and you really have involvement of the small and medium-sized vessels in the panniculus, which can have very characteristic appearance, and I'll show some examples. If you're in doubt, you can do your von Cussa stain, which is a good calcium stain. We don't need it, but it's good to at least be familiar with it. And then here's a classic kind of clinical image from Lever showing preferential involvement of fatty areas, and you get this sort of net-like pattern, ulceration. And histopathologically, we see these, this is what we see in a subcutis. We see these calcium involvement of the vessels down here, of the small vessels. And then we also see some medium vessels involvement as well. So sometimes, though, it can be tricky because you can think, well, you have some medium vessel involvement, but could it just be some degenerative effects from aging? So you really want to see some more extensive involvement of the underlying pannicular small vessels, and of course your correlation with the clinical presentation. So dystrophic calcinosis CUTIS is something we see every day. This is basically just calcium deposition in previously damaged tissue. The serum calcium and phosphorus levels are normal. A couple of important examples to be kind of familiar with is calcinosis universalis, which you can see in dermatomyositis, or calcinosis circumscripta, which you can see in systemic scleroderma, morphea, or Crest syndrome. So calcium is calcium, no matter where, what condition. It's all going to look the same. The distribution and the degree might be different. For example, here we have this very extensive involvement, but it's still going to be the same look microscopically, in that you get these kind of purplish granular material that's very easy to identify once you've seen it a few times. Okay, so I'll mention idiopathic calcinosis of the scrotum, of which the image I just showed you actually was an example of that. And I mention this because it's thought to be the end stage of dystrophic calcification of epicysts, epidermoid cysts, which I think is probably true because I've seen some cases with where you have coexisting large deposits of calcium with adjacent ruptured cysts. So idiopathic calcinosis cutis, I'll mention just briefly, no underlying disease. Tumoral calcinosis belongs to this family, and a condition in which we get these large subcutaneous masses, often around large joints. This is familial. These patients often have hyperphosphatemia, and you get involvement of this fibroblast growth factor. Here's another one we will see in daily derm practice every once in a while, subepidermal calcified nodule. I think of this classically as being these small nodules, maybe a few that occur on the face of children sometimes the ear, usually involving the upper portions of the dermis. So here we have an example of that. So you can see, as opposed to, for example, the idiopathic calcinosis of the scrotum, you can see in this case, which is an example of subepidermal calcified nodule, much more superficial involvements. And clinically, these will present as hard nodules. Okay, so mentioning another one that's actually kind of nice to see under the microscope because it's so diagnostic, we have gout. Clinically, these patients present with recurrent attacks of acute arthritis, and you get these deposits of monosodium urate within and around joints, and urate deposits, the classic tophi, which is the kind of the magic word that we think of when we think of gout. The classic location is helix of the ears, but you can get involvement of the olecranon bursa, fingers and toes. And there's probably both genetic and environmental factors involved. So there's a lot of talk about this fixation in absolute ethanol or ethanol-based fixative. And it's true, it does help a lot. It is nice to see that. You can see the crystals very nicely. You can show by refringence, but to be quite honest though, even if you don't fix it, it's still a fairly diagnosable disease. You can still even make out the crystals. I'll show you examples of what I'm talking about in a little bit. And we'll talk about these needle-shaped urate crystals and bundles, doubly refractile. And then you can get this polarization with red filter. to get these blue crystals. So here's images right here, and this over here, I don't know if this was actually fixed in alcohol, but I tell you, I've seen examples of gout that were not fixed in alcohol and still had these kind of needle-shaped structures. So really nice structures with the surrounding foreign body giant cell reaction. And again, very, very characteristic look. So an easy one to show you on your exams. And here's that blue birefringence. So ochronosis, again, it's a fun one because from the derm path perspective, because it's another one that's very, very characteristic and easy to show you in your exams because it's very diagnosable. Two types really, endogenous and exogenous. I've listed the endogenous type there for completeness sake, but really the ones that I've seen have all been from the exogenous or localized variant, which is secondary to this hydroquinone cream. I've probably only seen a couple of cases, but like I said, they are kind of fun to see. These agents inhibit homogentistic acid, and that's kind of the underlying theme of both the endogenous and exogenous variants, because that's what you get. That's the pathophysiology, this lack of homogentistic acid oxidase, and you get the accumulation of this homogentistic acid. So I just said these can be identical in both types, but you do get this ochronotic pigment, which I'll show you. I can talk about it, but it's much more fun to show you because it's so characteristic. And you get granules in addition to this pigment. You can get granules found in endothelial cells and basement membrane of sweat glands. And here we go. Here's our ochronosis. And here we have our very nice, I kind of think of them as banana-shaped structures right here, this kind of crescent or banana shape, very characteristic color to this sort of yellowish color to them. So that's one that you should know because they'll probably show you some example of that on one of your exams at some point. So we'll shift gears now to mucinosis. 6 types, which I'll mention. I'll go through these really briefly, but mucin is mucin. So mucin is going to be look at the same under the microscope no matter what condition, although the distribution and degree can be different. You have 6 types, and then it's important to know that mucin binds water. So it's generally washed away during the process of doing processing or dehydration. So you may only have these, what's left is a few little threads or what I call kind of stringy or beaded material. And again, it's easier to show you. So we will see examples of this. Colloidal iron or Alcian, not Allison, it should be Alcian blue, are the 2 stains that you can use. We use them very commonly actually, and they're really helpful because they stain a very nice bright blue color. And here's what I'm talking about. This is from Wheaton, a very nice blue color to this mucin stain. So generalized mixed edema, not very often biopsied from a cutaneous or derm path standpoint. These patients have hypothyroidism, and really mainly a diagnosis is made on special stains. I can't even say I've really seen an example of this. Pretibial mixed edema, though, just saw recently a very nice example of this. Classic anterior aspect of the legs, put orange kind of look to it, this sort of thickened skin, erythematous skin, associated with, of course, thyrotoxicosis or Graves' disease. These patients have exophthalmos, and this condition is rare in non-thyroid toxic thyroid disease. I talked about this a little bit. Here is our clinical image, that peau d'orange skin. And then here is, I was talking about earlier, that kind of stringy beaded look to that. That's this stuff right in the middle there between the red collagen fibrils. And if you want to do your mucin stains, your colloidal iron or Alcian blue, you can really bring that highlighted. So this is another rare thing, but I've seen a few examples, so you'll probably come across it at some point, lichen myxedematosus. So you can think of papular mucinosis, which kind of these densely grouped papules. This is probably one of the more common presentations, clinical presentations of this, often on the face and the arms. You also get this variant called the acropersistent papular mucinosis and a nodular variant. So I'm just mentioning those, but I really think of these as all being kind of part of the same spectrum. Now it's important to know the generalized form because this one is a little bit different in its presentation. Scleromyxedema, which is associated with a monoclonal gammopathy of lambda chain. So that's important to know, and that's something they'll probably ask you. These patients have thickened skin, sclerodactyly, plasmacytosis, or other cutaneous manifestations. But histopathologically, the binding thing between all of these conditions is that you have this in addition to mucin, you have this sort of fibroblastic proliferation. So you have the sclero portion of it. And the mucin is usually more circumscribed in this. You have variably increased fibroblasts, which is what I was just talking about. And importantly to know, scleromyxedema can actually resemble nephrogenic fibrosing dermopathy. Although this condition, this latter condition, tends to infiltrate down septae. And both of these are CD34 positive. So it can be tough to tell these two apart. And of course, if you get the history with renal disease, that helps a lot. So this is what I'm talking about. So you get more of this patchy distribution of mucin, a little bit up higher in the dermis here. And you have mucin here, but you also have this sort of spindle cell fibroblastic proliferation. So it's kind of a double whammy here in this case. So another condition I'll mention is reticular erythematous mucinosis. Probably a variant or related to tumid lupus. It has a lot of things in common. It has mucin. It has a perivascular, superficial and deep perivascular mononuclear cell infiltrate, which can involve hair follicles as well. So I think of this as sort of on the spectrum with tumid lupus and as an effect as well, Jesner's lymphocytic infiltrate. The difference in these two, in all of these conditions, at least for REM, is that you just get a little bit of much more limited mucin. So you can see here, there's just a few little pools over here, which you can see highlighted by a mucin stain right here. So it's just a little bit, it's one of these conditions, REM, can be very difficult to tell histopathologically because they can have very, very subtle findings, but probably on the spectrum with lupus. I did mention real briefly, just for completeness sake, self-healing juvenile cutaneous mucinosis. Not going to go too much into that one. And now we're shifting gears to talk a little bit about this scleroedema. These names can get confusing because they all sound very similar, but scleroedema is it's a little bit different in that it's very easy to miss histopathologically. You may see increased mucin in earlier cases, but a lot of times all you see is a thickened dermis, which can be very tricky because we get biopsies from areas of thick dermis all the time. So it can be one of these invisible dermatoses. I kind of file it under that. Think about it if you don't see something that's too obvious under the microscope. So you got the three groups: the abrupt onset within a few weeks of febrile illness related to streptococcal URI. The chronic form can be associated with a monoclonal gammopathy. It seems like everything can be associated with monoclonal gammopathy. And then, of course, diabetic associated kind that persists. And basically, this is a condition where you get a thickened dermis, no increase in fibroblasts, but you get the space between collagen bundles, or this fenestration, which is supposed to be the characteristic look to it, but it can be easy to miss. And you can get systemic involvement as well. So here's an example, and this is what I'm talking about. Like, we get a biopsy like this one in the upper left-hand corner, a very thick biopsy, maybe some fenestration splitting between collagen bundles here, but boy, I tell you, I'd have a really hard time knowing what was going on without any additional history. Of course, if you get lucky enough in earlier stages, as I was saying, you can get some increased mucin, as we see in these two panels down here. And then the mucopolysaccharidosis, I'm not going to talk too much about. We could do a whole other hour on these things, but from a derm path perspective, really the only thing that kind of the magic buzzword that you need to know is metachromatic granules. I've never seen a case of this, and they didn't even have an example of this, an image of this in any of the major textbooks. So Reliever or Whedon. So I didn't put an image of it there, but just know that I think from derm path perspective, they may mention if you ever hear these terms, you can associate it with mucopolysaccharidosis. Now this is a condition that we'll see acanthosis nigricans. Probably very familiar with the clinical settings, the malignancy associated one, which is important to know because of that association with gastric adenocarcinoma in particular, but other conditions. You get these tripe palms. It's something that's been described. The benign variant, the syndrome or insulin resistant variant, obesity associated, inherited, drug induced, and mixed. Under the microscope, these are all going to look the same. So I'm not going to go too much into the different types, but we'll try to focus on what we see in particular under the microscope. And what do we see? We see this papillomatous hyperpigmented patches, usually in intertriginous areas, giving the histologic appearance of this church spire. So this is really the one that I think of that has that really good church spiring or very, very pronounced papillomatosis. And it's pretty characteristic. So in the context of a rash, if you see something that has this church spire, first thing you need to think about is acanthosis nigricans. It can involve the mucosal surfaces and be extensive in the malignancy associated types. And the clinical or the histologic differential diagnosis, often in my mind, there's really three things when I see this church spiring. I think of nevus, epidermal nevus, SK, to some extent CARP, confluent and reticulated papillomatosis, although I think of this as being much more blunted. So the real only differential diagnosis is going to be epidermal nevus and SK. And then it becomes fairly easy, because if you have those things in mind, and if you know you're dealing with a rash, you got your diagnosis, as opposed to a solitary lesion or limited lesion, in which case you'd go for these guys down here. So here's what I'm talking about. This is from Whedon, this really nice papillomatous church spiring, very characteristic look. We can even tell it's from the axillary area because we got probably some apocrine glands down there. And CARP, some people think this is kind of a variant of acanthosis nigricans. But as the name implies, you can get confluence in the center and reticulated appearance at the periphery, and you get these slightly hyperkeratotic and papillomatous pigmented papules in a symmetric distribution. And as I mentioned earlier, is it a variant of acanthosis nigricans? It's possible. There's this thought of being related to Melissasia furfur, the commensal organism, so it's an important association to know. A few cases I've seen of CARP do have it on. I often will see, but it's hard to know if it's cause and effect, although some studies are suggesting that it is probably related to it. And this is what I'm talking about, a sort of blunted more look to this, as opposed to the nice church spire, the nice really pronounced papillomatosis that you see in acanthosis nigricans. And this one, it's much more blunted, sort of flattened out. So this one, another one I'm just going to kind of mention, not going to talk too much about him, hereditary hemochromatosis, the iron deposition disease. You do get pigmentation of skin in about 70–90% of patients, often mild, but interestingly, this is mostly due to melanin. It's basal layer hyperpigmentation as opposed to iron deposition, although you do see iron deposits by special stains around blood vessels, macrophages, and the basement membrane. Actually never seen a case of this biopsied, so. Phrinoderma, again, another rare condition because we just don't see this nutritional deficiency in the US very often. In some cases of surgery, of small bypass surgery, you can see it. And you get this, a couple of things in the skin, you get this dryness and roughness of the skin, which is caused by this hyperkeratosis and the follicular plugging, although really histologically it's not the most specific finding. It's not like you could look under the microscope and say, oh, this is obviously phrinoderma. It's not going to work that way. But under the correct clinical, you can certainly suggest it. And of course, you get the involvement of the eyes, which is very important. These patients can develop night blindness, keratomalacia, xerophthalmia. Pellagra is a good one to talk about here because it's one, I think of it under this umbrella term of all the nutritional deficiencies. This one in particular caused by niacin deficiency or its precursor tryptophan. Often these patients have nutritional problems, so they can be chronic alcoholics, patients with anorexia nervosa, in some cases even carcinoid patients. Drugs can cause it. And classically, what we all learn in med school, the 3Ds, dermatitis, diarrhea, and dementia. But I mention it here because of the kind of common histopathologic appearance that you get in this, as well as other related nutritional disorders, which we'll talk about in a minute. So you get symmetric, frequently painful photodistributed lesions. The histology can be nonspecific, but sometimes you get this pallor if you're lucky, the psoriasiform change and this pallor in the upper portions of the epidermis. And these are these other nutritional processes I was talking about, with the exception of psoriasis, acrodermatitis enteropathica, necrolytic migratory erythema. And psoriasis can have it's thrown in there because it is sort of a psoriasiform pattern as well. Older lesions show hyperkeratosis and parakeratosis. And this is what I'm talking about, this psoriasiform pattern with sort of this pallor. Sometimes you get parakeratosis. Not the most specific, but certainly if I see this, I'm going to start thinking about going down the road of the psoriasis or conditions of nutritional deficiency. And a really nice example here in Wheaton of this very, very pronounced pallor of the upper portions of the epidermis, and then you get some psoriasiform change as well. And in heart-neck disease, another one that can actually have this sort of similar nutritional look to it. I'm just going to mention it really briefly in that it is similar to pellagra clinically and histologically. The enzymatic defect in this case is in the transport of tryptophan. And then this, again, I'll just mention real briefly, just for completeness sake, no really specific histologic findings in tyrosinemia type 2, but it was in the chapter, so I thought I would just mention it and for completeness sake. So we will now try to move on to a few unknowns cases of slides I'll show you. Okay, so we'll go back to our slides here now, and we see this first case. I'll just kind of talk through what I'm seeing, and we can discuss a little bit about an approach here. I think the most obvious thing on this punch biopsy is that we have this very nice subepidermal blister over here. Not much really in terms of inflammation going on here. So you might think, related to what we were just talking about, we think about PCT, and actually this is a very nice example of a PCT. Not the greatest festooning, but we do have a little bit of this sort of pushing of these papillary structures into the spaces right there, but not much in terms of inflammation. It can be tricky sometimes to see the thickened material around blood vessel structures, but I think if you look at this vessel right here, you can see that you do have some duplication of the basement membrane material, thickening of the wall. So I think that there is, if you want to do a PAS stain, which unfortunately we don't have in this case, you could get your diagnosis, a PCT. Of course, you correlate it with the clinical as well. Other things you can think about, EBA, you can think about some other conditions that give you subepidermal vesicles, anything that basically involves the dermis, so anything that weakens the dermis, things like amyloid and things like that can actually be considered as well. So that's a nice example. Let's move on to the next case. So this was just an example I wanted to show because I wanted to show an example of mucin. So you can see here we have a sort of a lighter stain to the quality of the epidermis right here. Sometimes I like to compare the central area where the abnormality is to the peripheral area because it's kind of an easier way to tell you what's going on and what's what the pathologic process is in contrast to the non-pathology involved portion of the skin. So here we have the papillary dermis over here, which looks nice in this kind of red and fibrillar, which is what we would expect it to be. But centrally, we have this very pale area, almost like a nodule right here. And we have this sort of bluish appearance. Maybe you can squint your eyes and imagine that has a bluish appearance. So this is an example of mucin, actually. And I just wanted to show it because as an introduction to before we talk about other mucinous conditions. If we wanted to do a colloidal iron or an Alshan blue stain, we can certainly do that. And this would stain, again, that blue color that I was showing earlier. All right, so let's go on to our next one. Okay, so now we can talk about this condition, and we'll come back to the mucin thing in a little bit. So here we see this shave biopsy that has this sort of papillomatous appearance to it. Not quite the church spire appearance that I was talking about earlier, but nevertheless, you do have areas like this, almost like a waviness to it. It just doesn't quite look normal. And again, if you compare to like the edge over here where you have uninvolved skin, you can see that it looks right over here. It looks more flat and more normal kind of appearance to the epidermis. Certainly we have some areas that are a little bit thick and a little slightly papillomatous. And if we were to check our history, we could see that this patient has symmetric reticulated areas of pigmentation, or what appears to be hyperpigmentation. And this is actually a nice example of CARP, or confluent and reticulated papillomatosis. So as I said earlier, is this a variant of acanthosis nigricans? Well, I certainly think it could be. I mean, it's not the most church-spired here. It's just more of this blunted kind of look to it. You can also find, as I mentioned earlier, if you look hard enough, we can find some bugs in there. You can Melissacia furfur, which if I find them, it'll be great, but I honestly did not look too hard, so I'm not going to spend too much time looking for them. But there is certainly an association there. So this is something that you can, I think, of one of these conditions that you can put under the microscope and start thinking about it. It's maybe suggested in your mind, but it does kind of require a little bit more of correlation with the CPC and to really make the diagnosis. But again, one of these things that I think about as being this sort of milder version of acanthosis nigricans. All right, so we'll move on to our next one. So this next condition, again, low power. We kind of scan this whole area here, and we can see that there is quite a bit of papillomatosis, much more compared to the last one we were just seeing. Much more of this church spire appearance to it. You can see it's kind of protruding out there in a very, very papillomatous fashion. So this is one that I would think, if this is not a solitary lesion, for example, if they didn't say rule out SK, or if they didn't say rule out epidermal nevus or something like that, they told me, hey, this is a rash, this is intertriginous, that's hyperpigmented, then I'm thinking, you know, acanthosis nigricans. So this is a really nice example of it. Very, very nice church spiring right here. Nicely contrasted to the case of CARP, which I was just talking about, which is kind of, again, a much more blunted version of this. And as I said earlier, all these cases of acanthosis nigricans can be very similar histologically, so really no way to tell them apart. Okay, we'll move on to our next one. Okay, so here we have this Shea biopsy, and not have a whole lot here. It's kind of a superficial biopsy. We have some solar damage right there, probably sun-exposed skin, a few folliculosebaceous units. But then we have something right here, something that doesn't quite belong there, sort of a deposition thing. And again, I'm thinking deposits. I'm thinking starting to go down things that can get deposited in the skin. And if you look here, you can start to make out the shape of this deposition material, and also a foreign body giant cell reaction. So the body doesn't like it. It's elicited this foreign body reaction. It's a foreign material, but can we make anything out of it? Well, if you look closer, I think that there are areas right here where we sort of have these needle shape quality, maybe over here, a little bit of this needle shaped quality to these that's comprising this sort of eosinophilic material. So this is a nice example of gout. Interestingly, the body does, as I just mentioned, have this foreign body reaction to it, but not to some of the other deposition disorders I was just talking about. For example, like amyloid, you don't see a foreign body giant cell reaction. I'll show you another one. Oops, I actually want to go back. Another example of gout, sort of a more robust one in which you get much more of a foreign body giant cell reaction here. So this kind of material that's rimming this gouty tophi material is actually a foreign body giant cell reaction. And this is the ear, this location. So this was a much more classic location, much more robust example. If we look closer, we can see that we can kind of make out that sort of needly kind of material right over here, maybe this area right over here. So we could do our biorefringent. It doesn't work too well unless it's been fixed in alcohol. But this is an example, and I think the prior one as well, that were not fixed in alcohol, and yet we can still easily make our diagnosis. There's no question that that's what this is. Again, you can still even make out this sort of needle-shaped material, even though there was no fixation in ethanol. So very characteristic. Once you've seen it a few times, it's actually pretty easy to diagnose. Okay, let's go on to our next case. Okay, so here is an example of a punch biopsy, a fairly deep punch biopsy. And as I said earlier, sometimes I'd say I like to look at the normal areas to compare to the involved areas, but here there's not a whole lot of normal. I mean, there's maybe a little bit of uninvolvement of the papillary dermis over here, and maybe an area down here where you get this sort of collagen that's semi-normal, but it's been splayed a lot, and there's a lot of this bluish material, which we were talking about earlier. It's a very nice example of mucin. So this is quite an extensive amount of mucin, and really, when you see this much, I've only seen a few cases of this, you really have to think about it when you see this much deposition. That's so easy at low power. No need for mucin stain here, although if you did your colloidal iron or Alcian blue, it would light up like a Christmas tree. But this is an example of pretibial myxedema, and this is kind of a classic example of it, when you get so much deposition of it. The clinical, I saw the clinical images for this, and it fit very nicely. And this is a really nice example of mucin at higher power, because as I was talking about earlier, you get this really beaded, sort of stringy look to it. It's very, very classic. Nice to see it at high power, but again, at low power, it's so characteristic that you really don't need to go so close to make your diagnosis. So very nice example of pretibial myxedema. And this patient did end up having Graves' disease, so it fit very nicely. And again, one more higher power look if you want to take a look at that beaded material, that stringy material, really kind of this overall bluish tinge. And as I was saying earlier, mucin is mucin, so no matter what condition you're talking about, it's always going to have the same appearance, but the difference will be in the extent and distribution, which, as we can see here, very characteristic for pretibial myxedema. Okay, we'll go on to our next one. Okay, so here is an example where we have a punch biopsy of what looks like fairly normal skin, thick skin, but the pathology is not within the dermis. You can sort of see, I would think about, if I were approaching this, the invisible dermatoses. So you can sort of see that there's not much going on here, but maybe a little bit of elongation of these ridgy ridges and a little bit slight distension of the papillary dermis right here. And this eosinophilic material, which actually is a nice example of primary cutaneous amyloid. Sometimes the clue, because this is sort of this invisible dermatosis, sometimes the clue can be this material right here, which is melanophagous. They can draw your attention to it because they kind of go hand in hand. I mean, this is sort of an inflammatory process. It's a condition that over time can develop pigmentation, post-inflammatory pigmentation. So if you follow the melanophages, you can sort of, they lead you sort of to this amyloid material, which you can see really nicely right here. Don't have the Congo red stain or the crystal violet, but if you wanted to, you could look at that and make your diagnosis, but there it is really nicely right here. And there's a few even necrotic keratinocytes, I think, which, as I was talking about earlier, since these are all cytoskeletal in structure, right over here, then it would make sense that you have sort of this dropout, which is not uncommon to see in primary cutaneous amyloid. You have this sort of dropout of individual keratinocytes. And here's an example where it's a little bit more epidermal thickening involvement of the epidermis. So this patient's probably been scratching, and you get more of this LSC type process, but you still get your deposits down there as well. So this is more of this lichen amyloid. And again, necrotic keratinocytes kind of to go with it. And as I said earlier, sometimes you can, they say you can do the cytokeratin stain, which I guess, I mean, it's true, but it's just, I haven't had a whole lot of luck. I've tried it a few times. Usually what I end up doing is more of the colloidal iron, or sorry, or the crystal violet or the Congo red, if need be. All right, and we'll look at one last case here. So this is one I said earlier, once you've seen a couple, you kind of will be set because everything looks the same. Calcium is calcium. This very, very characteristic bluish deposits of material. No problem here. I believe this might have been a case of tumoral calcinosis of the scrotum, or possibly subepidermal calcified nodule. I can't remember for sure. But these dystrophic calcifications, the large deposits, very, very easy. Where you sometimes run into trouble is like examples of calciphylaxis, where it can be much more focal, involving the small vessels. Sometimes it can be spotty and you have to do levels and look in your panicular tissue to identify the calcium within the vessels. In those cases, you may think about doing von Costa stains or something, but no need here in this example of calcium. So it's calcium is calcium. It's going to be the same appearance no matter what condition. Again, differing in the distribution, extent, and of course in your clinical pathologic correlation. So with that, I'll stop. I hope this was helpful. I hope that you learned something, and we look forward to the next time. Thank you for listening.